you and Dr. Costi talk in part of the book about the patient's account, their perception of the problem, the behavior of the pain, and we gather in that history. Talk to us a bit about what the book offers related to the subjective exam.
Yeah, in chapter 3, Melissa and I did a really good job about tackling the 3D pain assessment. Pain assessment should involve the sensory domain, obviously. Where is it? How bad is it? What's it feel like? Is it coming and going? It really needs to get those sensory determinants. All right. Now, the attentional domain, what they know about it is just as good. What do they think about it? What do they think that pain means? What do they believe? What have they been told? What have they read? Really drafting from them. What's making it better? What's making it worse? That's a part of the questions that really, give value to that person, that they're a part of this assessment. And this is a true partnership. That attentional domain. And I think we did a really good job in chapter 3, giving you concrete questions that should be a part of an exam, because it really frame sets where they're coming from or how their internal model of assessment is really driving the perception of their own nociception. And then we took it a step further and laid down that groundwork that's been around for decades relative to how is this affecting their life, the affective dimension, and whether you're using yellow flag risk forms to quickly screen, the yellow flags that we know about, fear avoidance and self-efficacy and emotional coping and, sleep. These domains that are huge in the respects to how it's affecting or infecting their life. And so, in an assessment, you have to be able to, walk yourself through a funneling method that's going to look at the sensory, look at the attentional, and look at the affective. And I really feel like if this is a new area for you, chapter 3 will really open your eyes to a 3D assessment, a 3-dimensional assessment.
Mm-hmm, mm-hmm. So you're mentioning briefly some of those classifications within pain mechanism classification system as we're talking about. So can we just talk for a moment in the subjective? In the next 4 or 5 chapters, you guys break down each of those classifications themselves. But let's just, before we jump into each of on their own, maybe we just kind of, give us a clinical picture of what the patient's going to say for patients who aren't in that active disease state, who aren't in that nociceptive stage. They're in some of these central sensitivity, autonomic, or affective type of classifications. They would at least be consistent with those. What's that patient going to look like? Just help paint a picture of maybe some of these areas that some clinicians aren't as familiar with.
Well, let's take location of symptoms. I always think that's a good one. Everyone should be looking at location of symptoms, and we're taught to, make sure and clear the rest of the extremity. That's huge when somebody comes in and says, my shoulder hurts, and you're asking them, do you have any other symptoms in that arm, right? Mm-hmm. But do we go and really say, hey, do you have any other symptoms in other parts of your body? Are we really screening for the presence of widespread pain? That would be a huge indicator when someone's saying, yeah, I've got symptoms in my right arm, in my right leg, I have history of symptoms. I actually have symptoms in my left leg. Well, when you start to draw all that out, someone would argue that looks a little bit like widespread pain. That could look a little bit like someone's either dominated by central sensitivity or motor autonomic, the 2 widespread pain mechanisms, Now let's talk about the affective mechanism, right? Those widespread mechanisms seem to be connected and seem to be spreading. But the affective mechanism, I've always loved looking at location of symptoms. They're not going to give you widespread pain, but they'll give you multiple sites. Oh, yeah, I got a knee. I tore up my ankle when I was younger. I got a shoulder, and those sites could rotate on you in significance relative to different things that are going on within their life. So how well in location of symptoms do we really look for the presence of widespread? Because that right away puts two mechanisms up there to be ruled in or out, depending on how you like to say that. Or is it really that people have multiple things that they're dealing with, but they're just coming to you because you're the knee guy and you're not really understanding? Because that knee guy, after several visits of the knee, could all of a sudden become the shoulder guy when you're ready for the old discharge, because he really has formed a bond and a partnership with you and coping with you and, shifts. So location of symptoms, I think, within the central nervous system is huge. I also think frequency, within the central nervous system. We know, motor autonomic and central sensitivity are going to have a constantness to it, where the effective mechanism is usually intermittent. Central sensitivity, I love hearing better and worse in central sensitivity. They really can't find relieving activities. Everything makes them worse. I think they frustrate MDT clinicians because we're so trained, to look for those patterns, and you want to make amends with them, but they really throw you off because, at this present moment, they are coming from the belief that everything hurts and everything is harmful. And so now you can't get a clear, they're telling you palliative procedures are far more effective than any type of position or movement. They're shifting on you, people that are in the effective mechanism with better and worse love heat, love massage, love acupuncture, their med choice are more mood stabilizers, so, they're coughing it up. I love motor autonomic. They're about, those poor people, I don't know. They don't know where their limb is in space, let alone what's going to affect it. They're often the ones that when you ask them where their symptoms are, they're like somewhere around here, they have lost recognition. So, where essential sensitivity, my gosh, they give you detail, but because they know where every nociceptor is in yours, for crying out loud, so there is these distinguishes that really can yield things as you're collecting, but you got to know how to ask that follow-up question too. And you got to know when they really don't know, you got to let it go. And I think, who is it? Mark, one of the greatest of greats, right? Mark Miller. I think when, he'll say, look, if they're doing, I don't know, you get out of there and you start testing, because at that present moment, all it becomes is conflict, and so I think you can go through questions and really see those details outline themselves to give you more information relative to that. And
hear the entire episode for free on iTunes, Spotify, other favorite podcast players, or go to mechanicalcareforum.com.